Good morning.
How are you today?
Sorry, I'm kind of a
Welcome to the conference. We're waiting for all the attendees to log in. Hello, Greg. Welcome to the conference. Hello, Greg. It's Eric. How are you? Greg, I got your message. No working microphone today. Eileen, I get your message. You're trying to unmute. Good. Hello, Jerry. How's the weather in Utah?
It's beautiful.
Great. It's good to have you to the conference. Greg and Eileen are self-muted. Jerry's up. Shato's up. And we're waiting for everyone, the attendees, to log in. Okay, we're waiting for one more login. Susmita is coming in. Greg, it looks like you came in by telephone. Eileen, it looks like you circumvented and came in by telephone also. Good.
Can you hear me?
Yes, I can.
Oh, great. Okay, thank you.
Okay, you're welcome. Greg, can you speak?
Yep, I'm here.
Good, Greg. Waiting for one more login.
All right.
Can you see a video cam?
Yes.
Oh, you see someone sitting in the dark there? That's our patient, Frank Sperlin.
He doesn't appear to be in the dark to me.
We're waiting for Susmita. Is she with you, Greg?
No, she's not with me.
Okay, she is a late login, but just send her an invitation. Okay, we're going to go ahead and get started. Welcome to our cardio-oncology webinar. Today we're here for a case presentation, and I'm very honored and privileged to have on the webcam Frank Sperlin, who was my patient many, many years ago. And you'll see on the screen here a proclamation from the mayor that was honoring him on Heart Transplant Month, which I presume was in January because that's when this was put out. And at that year he was being honored for having had a cardiac transplant 25 years before. So let me get the next slide, and we will talk about Frank Sperlin today, who is 29 years post-op heart transplant. He had an osteosarcoma of his right leg, which was detected by the cancer team, and he had amputation of that leg, and then received Adriamycin among other medications. It's been so long ago since I took care of him that I don't remember the dose back when he had that, but it did cause him to have a decline in his ejection fraction. And let me move on to the next slide. He was 34 years old at that time, and his ejection fraction declined to about 10%. And actually, it's not dobutamine, but it was dobutamine that he received, and a drip. And he was in trouble when I met him, and he was sleeping all the time and had a low cardiac output, was in congestive heart failure, and it was just sort of the last minute type thing. He was transferred to Tampa General, and we had done our first cardiac transplant and had come off of that with some celebration, and it was very complicated for us to have accomplished that. Matter of fact, at the last minute there was some certification that we needed to have in order to be able to do that. And we actually flew somebody in from Dr. Shumway's program at Stanford, and brought him over to our hospital to give us the credentials we need to get certification. And so we accomplished that, and then flew the gentleman over to Lakeland in a helicopter. I took him over there, and that was the premier cardiologist of Dr. Shumway's program. And so we got the certification we needed, did the first transplant, and then Glenn came along as our second transplant. There was a gentleman who had a motorcycle accident and was brain dead, and his heart was brought in from Myrtle Beach, South Carolina. Dr. Vijay, Dr. Eckstein, and Dr. Sweeney participated in this procedure. It took about 3.5 hours. And actually, cardiac transplant turned out, from my observations, to be a very easy procedure. I always thought it was going to be a tough surgical thing, but it was very simple. And they basically cut some of the heart off the left atrium and right atrium and then sewed back the new piece. And everything went very smoothly, and I was extremely surprised. We've had a lot of prolonged cardiac surgery. This was not prolonged. 3.5 hours was nothing in the OR for cardiac surgery. So I was amazed, because we had patients with ventricular defects and posterior aneurysms that took a lot longer than this. And so this was a slam dunk for a cardiac surgical procedure. And I found out that, we've always talked very highly of the cardiac surgeons who do this procedure and said, oh, that's amazing. And I found, hey, that's a lot of hype. It's really pretty simple. And the problem is the post-op care. And so I moved down to the Bayshore from Carrollwood Village, where I lived like 12 miles away. And I moved down so I would be available. So I was right near there, so I could be at the hospital in 5 minutes. And so I would go back and forth taking care of Frank. And, of course, it was all a new experience for all of us. And Frank just happened to have a perfect match. And so Frank made it easy for me, and it was very convenient to have someone as a second patient who happened to be a perfect match. And so he's been, since that time, he's been having some hypertension, hyperlipidemia, type 2 diabetes. He has gout. He had a hernia repair, and at that time some exploration, and he was discovered to have liver cirrhosis also from his chemotherapy, which was something that we didn't know about at that time. We've certainly learned a lot of things about him as we've taken care of him, and because of steroids he's received, he's had aseptic bone necrosis of the left hip and had that replaced a couple times. He's had some ablation for arrhythmia in 1998. And diabetes also secondary to steroids. But as time goes on, he's required very little in terms of maintenance anti-immune therapy. And so it hasn't been too bad. He is now actually 29 years. At 25 years, he had an echo that showed ejection fraction that was fine, and the latest ejection fraction has been fine. I'd like to show you some of his studies, so we'll get his echo up here so that we can get current with how he's doing. And so, Greg, would you like to take a look at his echo?
Sure. So this first on long axis, I can really only see the but it, looks like it's moving fine from what I can see. looks like a normal wall thickness, which is a good sign in people with post-transplant hearts.
There's your Doppler study. Greg, would you like to continue to comment as I scroll through these images?
Yeah, sure thing. Maybe trace AR, tracing myself, but touch MR, nothing really spread over. Is this the tricuspid valve?
Correct.
Yeah, you know, his RV actually on the sternal lung could be a little generous. You know, probably moderate PR here. Although I can't really see the whole rest. This is the parasternal short, it looks like, which is another just the aortic valve. This is the pulmonary valve. Tricuspid valve again. Maybe more than mild PR there. This is his PR gap. So we'll see, depending on what it actually looks like, you have some pulmonary things that look like it can be better. This is the apical fluid chamber of the plastic transplant atria. You can see the sewing wound. And you know, this right neutral flow into the left a little bit of light. Pretty tough windows, but just solid function looks okay.
Pretty images.
You know, these the septum can be hard to tell exactly what's going on sometimes. These guys can just post pericardiotomy, especially if they had a smaller heart than they were, you know, pre-transplant. The septum can have funny motion, but this looks like it's really kind of bulging over, like you know, RV, perhaps volume overload even. There's that TR again. Sometimes this can happen just from post-transplant biopsies. You know, people get so many biopsies post-transplant that pieces of the chordae get bitten off, and they can have TR even without super high pressures. So this could be from that, you know, and a volume overload type of thing. The other apical views. Again, tough windows. Subcostal view. LV function grossly normal. The IVC is maybe a little generous. probably estimate his right atrial pressure to be about 15, which would give us a RV systolic of around 55.
I think he's been noted also to have some cirrhosis of his liver from chemotherapy.
Yeah, it does look a little nodular. So that was diastology. You know, post-transplant, I guess because of atrial mechanics and a number of things, I don't know how well validated our diastology that we use in everyday life otherwise is, but I think that a somewhat restrictive pattern can be even normal post-transplant.
I think Dr. Weston, who's one of this patient's doctors, has written some articles about diastology in transplant patients.
Yeah, I think it was on the echo boards, actually. I don't know if I got that one right or not. Looks like we're back to the beginning.
Okay, thank you. And we've got a great echo. Thank you for looking at that. And now we're going to show the cardiac cath. And so we're going to change the presenter to do that. So hang on just a minute. Got to go to the other screen. Let's see. Hello, Jean. Welcome to the conference. I just unmuted you.
Hello.
Hello, Sasmita. Welcome to the conference. I just unmuted you also.
Hi there.
Hello?
Hang on just a second. Testing, testing, 1, 2, 3, 4. Can you hear me? Testing, testing, 1, 2, 3, 4. Can you hear me? Very good. Okay, we're looking at the cardiac catheterization. And you can see that the left anterior descending is totally occluded. Left anterior descending is totally occluded. Just dropped out.
No. I needed you to have a background.
I'm not. Hello, can you hear me? Oh, okay. Left anterior descending is totally occluded. And we see circumflex circulation. There's some ghost of vessels over there as it slowly fills. So let's go look at the right, and we'll see collaterals coming from the right, and there's filling of the left anterior descending. And you see mostly septal perforators, as well as a collateral going through the AV groove, it looks like, going up to the circumflex, filling a circumflex vessel. And there's maybe 2 posterior descendings down here, one of which has a severe disease and is occluded. And then there's some disease also in the right ventricular branch up here that you can see as well. All of this is consistent with the vasculopathy that you see post-transplant. But the left ventricular function is well preserved. Looking at this ejection fraction of this patient, you can see the left ventricular function looks great. Let's go back one more time. And we'll look at the right coronary artery, and here's the disease in the right ventricular branch proximally. So it fills kind of slowly, and there's also some distal disease in several of these vessels, and lumpy bumpiness of the vessels. But this collateral system appears to be very functional in that there's no decline in ejection fraction. So that looks pretty good. So we'll take that one off. And minimize that. And we'll go back to the other computer. See if we can get back here. This is the one that we want to make the presenter. Oh, actually, we can stay on here and show Mr. Sperlin and do a little interview. So let's do that. So I'm going to stay over here, and we're going to see Mr. Sperlin here. So let's get move this over here. We've invited Mr. Sperlin to be here with us today, and we're going to ask him a few little questions, and so I'm going to put him on. He's been my friend for a long time, and this is kind of a reunion for the both of us. I haven't seen him for a while, and he hasn't changed a bit. You know, the rascal. The rest of us have sort of gotten gray, and he looks pretty good here for Mr. Sperlin does, so I'm going to put him on.
I remember waking up and them telling me they had fireworks going off. And this was July.
Oh my goodness gracious. And the date of the transplant was sometime in May, wasn't it?
No, June the 21st.
Oh, June 21st. Okay. And so you woke up for the 4th of July which happened to be my birthday, and also the country's. And so so what do you remember after that in terms of the recovery and stuff?
A long process. You remember staph infection, and that had to be treated. And I was weak as a kitten. I was down to about 115 or 20 pounds from 185.
Wow, that's remarkable. And so, how did it go in terms of your recovery and stuff?
I thought it went great.
Yeah.
Yeah.
And then how's life been, post-transplant?
Fantastic.
Yeah. Has it been restrictive that you have to go in and get these biopsies?
Well, that's a piece of cake. Well, you've done enough of them.
Right. You've been on the receiving end, though. Thank goodness.
Well, there wasn't all that much discomfort to it. I like to watch it. I learned a lot from watching the heart casts about the heart and about the body and everything else. But to me, that was just something that is like taking aspirin for a headache, or now in my case, it's Tylenol. But it's something that you can do and just go on, pick it up and go.
Yeah, are you on very much the way of medications now?
Very little rejection medication. I'm taking 25 milligrams of Adriamycin cyclosporin and in the morning, and 25s in the afternoon or evenings. And that's basically it, other than I'm taking Rapamune every other day.
Right. Tell me about before you had your transplant, about the sarcoma. When was that?
This was in '77. Started out just a bad pain in my leg. It'd go numb every now and then. And then they did the biopsy and gave me the results and told me what was ahead of me, and which was that time they was not doing any kind of bone replacement. They was experimenting with it in UCLA, but Dr. Barden said you could take the bone out, flip it over, and I have a stiff knee the rest of my life, or you could do above the knee amputation and fit me with prosthesis, which that's what I accepted.
Let's see, what do they say the odds are for you getting recurrence at that time, or for survival?
Well, it's a problem in 7 years, 5 to 7 years. If it did reoccur, it would probably go to my lungs, and that would be the end of the bandwagon, so to speak.
Yeah, did you have to take a lot of chemotherapy for a long time or a little time?
I took chemotherapy for a year, which is what destroyed my heart. I had to take it every so many weeks if my body would handle it, and if it didn't, then I had to pass on it. But I took it 10 doses, and they should have altered it on my 6th one, and they didn't. They should have stopped it at the 7th one, but I went on to 10. That's what did the damage. But this is all experimental, It's just like with the heart transplant. It was just something that was available at the time that I was fortunate enough to be in the position to work with it. And so it didn't pan out like everybody thought it should, but that's life.
How many drugs were you on?
Oh. There was 3 of them.
Where were you getting the chemotherapy?
At Lakeland, at Lakeland Regional.
And were you pretty sick when you got the chemotherapy?
Whew, man. I ain't never been sick in my life. You constantly had the heaves. You get into the dry heaves, which would just destroy your throat, so to speak. You couldn't taste anything for about a week, but you had to eat or you would really go down on your weight. And you'd have to eat, chew and swallow real slow, or it'd come back up on you.
Yeah, after chemotherapy, how long was it that you found out there was something wrong with your heart?
This was in 77 and 78, and January the 1st in 85 is when my wife got the news. They didn't tell me. They told her.
So it was 85 when you first found out about your heart.
Right.
Were you getting sort of sick then, or did you realize anything was going on? Was there any kind of checks on your heart from 78 to 85?
They were, but the only answer we ever got from the doctor was my lungs were clear. And see, this was the impression that everything was okay, because this is what we were concerned about, is reappearing in my lungs. And no question was mentioned or asked about the heart, which he didn't have to tell me. And in the point that he knew damage was being done, I don't know.
Yeah, were you getting these echocardiograms every once in a while?
Yes. But you never, you don't. At that time, you didn't question what the echoes, cardiograms was for, EKGs was for. This is just formality, and you accept it and went on. And
those were early in the days of echocardiography.
Right.
Set that up in Tampa General in 1974.
Right.
So that was kind of early in the days.
But
the old echo line machines then.
right.
Yeah. Okay. So then, when did you first start getting symptoms from your heart?
This was probably in October or November of 84. But again, now see, we excuse me, we didn't know that this was my heart was doing the problem. We thought this was all from a sinus infection, a fluid buildup from other sources, and there again, we were concerned about the lungs.
Tell me what you remember about deciding about going to Tampa General and so forth.
Well, I remember them coming in and talking to me about a transplant. And at that time, I didn't know what they were talking about. And I said, let's go for it. And I remember the ride over, which was a kind of bumpy, bad springs in the truck or the ambulance, but actually it's because I've been laying so still. But to me, any kind of extreme motion just rocked me.
You were being transferred from Lakeland Regional Hospital to Tampa General?
Right.
And they transferred you by ambulance?
Right.
Because you were sick?
Right.
Yeah. How long did they say you were in the hospital before you got the transplant? Tampa General?
About 6 or 7 days.
Yeah, that's pretty fast then.
Yes.
Yeah. Okay, let's see if anybody has any questions. Ask the audience. Okay, does anybody have any questions they'd like to ask of the patient or the process here? I see Jean DeCaro is here. We have Tammy Polanski. We're going to switch over to our other computer. It'll be easier for us to get questions. So I'm going to switch over here in just a second. And so we're going to switch to here. Hello, we've switched back to our other computer to see if anybody has any questions at this point. So the field is open for questions. So, I'm back, and we're back at our main computer here. We've had to juggle around, and so we want to see if anybody has any questions. And so I've got our patient here, as well as me, who was the attending when he got his transplant. And so, Greg, I think you have a question.
No questions here.
Okay, great.
I have a question.
Yes.
Hi, it's Eileen Diamond.
Hey, Eileen.
From the NCI, and I just wanted to say thank you so much to you and your wonderful patient for coming on and talking with us about your experience. And I guess I'm just wanting to know how your day to day is now in terms of your quality of life and your ability to function and do the activities you want to do.
Well, as far as activities, my wife stays on me about slowing down, but I basically do what I did before. The ironic thing about it, Elaine, was that the weight restrictions that they gave me in the beginning was 25 pounds. My prosthesis weighs 10, and whenever I walk with it, I'm picking up 10 and plus. But as far as picking things up, I can pick up and walk with 100 pounds or whatever. I worked on engines. I still like to play around with them. So I stay as busy as I want to be and do just about what I want.
That is very impressive. That's great, given all you've been through. Thanks for sharing that.
Certainly.
We have Ron Crone, who's logged in. Ron, we're talking to one of the 10 longest living cardiac transplants in the world. I think he's moved up somewhere in the top 5 about this point. And for me, he's number 1. But we've known each other during this whole time. I took care of him when I was a young fellow down at Tampa General. And he's been doing really, really well. He had an osteosarcoma of his right leg and amputation and Adriamycin and several other drugs. And it wasn't until about 7 years later that he was found to have a cardiomyopathy and was on a dobutamine drip, transferred to Tampa General, was the second transplant that we had at Tampa General. And he just had a perfect match. He's doing very well. He's got some vasculopathy, as we showed on his cardiac cath, but he has normal LV contractility and has some diastolic dysfunction. And he's doing very, very, very well. So we're real pleased with that. Does anybody ever? Come over here again. We got to mute this. So we'll come over here. We're picking up the speaker of this. Yeah, speaker off the computer. It says when you take that one off, it goes to the next one. It says when you take that one off, it goes. Okay, we're back without echo. So we have Dr. Morales. Would you like to make a comment here?
I think you already mentioned it, but I think the longest living is 31 years. He made the Guinness Book World Records. It was announced a few months ago, and you're 29 years right now, correct? So you're up in the 5. So we're going to be seeing this gentleman in the Guinness Book of World Records pretty soon.
Okay, well, thank you. Does anybody else have any questions or comments at this point?
This is Eileen Diamond again. I have one more question.
Yes,
I'd
Eileen.
like to know, out of all the different things you've been through in terms of your cancer diagnosis, treatment, your transplant, and some of the issues around that, what do you feel has been the hardest thing out of all of these? Which one has impacted your life the most?
Well, you didn't mention the worst. The worst one was losing the son to leukemia. The rest of it is, it's just like walking through life. You just take it and go on. But the memories of walking and running and hunting and fishing and such as that, they are things that you think about, but you've got to accept the fact that you are alive and that you can still function. That's my main thing, is that I can still basically do what I want to, with the exception of that activities that are related to the amputation. But as far as my heart, I don't see any restrictions there. And the only thing that, as far as dealing with it, is the loss of the leg would be the hardest thing to deal with.
Okay. I appreciate that, because sometimes as clinicians we come up with our own idea of what's the worst thing for a patient. So it's good to have you tell us and ground us in your reality. So I appreciate your honesty.
Sure.
Thank you.
Mm-hmm.
As you can see from what we put on the screen, one of the greatest experiences has been his grandchildren, and he's so glad. And he's got 5 now. And another experience has been that he's had a very strongly supportive wife. And this is part of our team that's supporting him, but his wife has been a very strong supporter. And so that's been great about this. And so it turned out that I think our first transplant went sort of crazy when he got his transplant. He was jumping out of airplanes and doing all kinds of wild stuff. But Frank is a pillar of conservatism, and he's done everything he's supposed to do. His wife has been very supportive. He's enjoyed the life of being a granddad, and I just feel so happy for him and happy to have been a part of this team that has made this possible. At first, when we started doing transplants, we had a lot of questions about how much resources we were putting into that program and how much it was costing us. And we said, is this really going to be worth this, to take these people and give them a year or two? But we had no idea that we would be giving them 29 years. We had no idea that that was what it was going to work out because of the numbers that we had back then. And I guess the longest probably back then was maybe 5 years. Yeah, so we had no concept of that. And so it has turned out to be a very gratifying program. And I was very glad to be a cardiologist involved in the transplant team. And it was a pleasure to have started out with Mr. Sperlin as my first transplant patient. And it gets kind of monotonous for the cardiologist. We're doing another biopsy, and the biopsies are boring and very routine. And you say, why are we doing this? Why can't we do something non-invasive imaging? And we say they get every 6 months you get a cardiac cath. And you say, why am I doing this? It looks like the same cath we did last time. And you wonder, why won't we do coronary CTA? And let's look at the wall and see what we can tell about the wall of the vessel instead of looking at the lumogram. And why don't we do cardiac MR, which Dr. Morale used to tell you how much that could tell us. And somehow it seems like we're stuck in a time warp of repetitive biopsies and repetitive casts, because that's the way the program is structured. And I've often wondered why we don't expand into multimodality imaging, since we've found that so useful in everything else that we're doing. So those are some of my reflections as a cardiologist that's been practicing for 40 years. So thank you so much for everybody coming. Mr. Sperlin, I want to thank you so much for driving all the way over from Lakeland to be here. The first time I've seen him in, I don't know, 20 years or something. And so, yeah, so we're just really glad that he could come over and be part of this program. And we have recorded this. If anybody wants a copy of the recording, we can give you access. And if anybody wants to share with us, with other transplant patients as well as with their friends, I think it's worth sharing. So thanks so much for coming. We appreciate it, and look forward to next month. Bye-bye. Bye, everybody. And we'll sign off. We'll stop the recording.